Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to another episode of Islamicity Weekly. For tonight's discussion, joining me as always is my co-host Hassan Labuskakhni. And tonight, our special guest, inshallah, is Shaykh Dr. Muhammed Sheik, who is an alim, a medical doctor, and currently specializing in psychiatry. He is practicing with the Gauteng Department of Health. Assalamu alaikum and welcome to the show.
Assalam wa rahmatullahi wa barakatuh. Jazakallah khairan, Brother Anwar, Brother Hassan, for this valuable opportunity. And I hope, inshallah, I'm able to share some of my thoughts as well as learn from both of you.
When Sheikh Anwar introduced you, Sheikh Muhammad, sounded like he said a miracle doctor. So, inshallah, I just want to clarify to the audience, he's a medical doctor, not a miracle doctor, not that kind of doctor. He's a real doctor.
Alhamdulillah. I think, all miracles in the vision and in the qadr of subhanahu wa ta'ala, right? And we're just a means to help, means to assist. But hopefully, maybe landing up in miracles too, bi'ithnillah. Why not?
Being a qualified medical doctor from a reputable institution, as well as a lifelong student of the Islamic tradition, it's our pleasure tonight to engage you on a topic that's really close to the heart of every South African when we think about healthcare. We know the current state of the public healthcare system. Firstly, the very brave, valiant, and genuine efforts of many medical practitioners within the public space. May Allah reward them for the enormous work that they do. But we also know that they're doing these fantastic efforts under very trying circumstances, considering the state of the Department of Health. And citizens find themselves in a situation where, on the one hand, there's perhaps a under-resourced and strained public healthcare system versus a private sector that many people find unaffordable and they find it almost exploitive. And tonight's discussion is really going to be speaking about the private healthcare sector and the type of practices that are taking place within the private healthcare sector, how they can be improved. Why are the costs in the private sector so high that people find it unaffordable? The amounts of money that they are paying for private healthcare on a monthly basis, enormous amounts of money that ordinarily they would not have been paying had, one, the public healthcare system been working, but two, had there actually have been perhaps more effective regulation so far as the private sector is concerned. There is a feeling amongst the general public that their plight, that they experience within the public healthcare sector, their concerns are being exploited in the private sector. So I'd like to engage you on some of this here tonight, inshallah.
Inshallah. Jazakumullah khairan, Sheikh Anwar. And I think it's a very pertinent discussion around understanding the private healthcare sector and the different models used in the South African healthcare system. And I just like to acknowledge that when you send out your regards to all those various healthcare workers who, in their valiance, in their stride to do the best for the patients and for the greater population of South Africa, always doing the best in whichever cost, whether public or private sectors. And I think South Africa is not a very unique country in terms of having a two-tier model or two-tier system that employs state-funded healthcare as well as private-funded healthcare. And I'm using these words very intentionally, right? When I say state-funded healthcare and private-funded healthcare, and I think maybe we might just go through some of the disparities between the two, and ultimately the issue that surrounds both of these revolves funding. Each tier has its own challenges, right? The state, with the onset of corruption, the tenderpreneurs and their advances in ensuring that they capitalize on equipment at, sometimes 1,000, 2,000% above the general average expected rate. So that is quite rife in the public sector, and I don't think any of us are strangers to that. But I think the focus of tonight's discussion revolves around the private healthcare and understanding that. And there's a few things maybe we need to be cognizant of in understanding the private healthcare. Approximately maybe 9 to 10% of South Africans can afford private healthcare, either through their own um, private or through what we call a subsidiary like a medical aid, right? And it would seem that someone who is truly able and capable. So looking at the low to middle or middle to upper so-called class of financially able people are able to afford private healthcare. And that speaks to the greater question, why is private healthcare funding so expensive? Okay. And then I think the underlying subtlety to this discussion is, why then do doctors or healthcare providers charge such exorbitant fees, which I think is also part of your discussion that we're trying to unpack today. So look, in understanding the model, right? I think the fundamental difference for the common person like you and I, who's trying to grasp the concept of our healthcare systems, is that um, I think primarily in the state sector, the motto and the directive is primarily service driven, right? It's a service, and there's always cost restraints. Okay. Whereas the key element that defines the private healthcare system is a business model. Okay. They are offering you a service, but the priority is business driven. The ethos is business driven. Now, let me bring you into a picture. If you go into, as a patient, into government institution, and somebody has to take bloods from you, right? Maybe they might struggle 2 times, 3 times. Eventually, they do get the blood, or whatever investigation it is, right? There is some cost associated to that, but the cost is not reflected to you as the consumer, as the patient. If you go into private, and if Allah forbid, if anybody has any sort of experience in the private healthcare, and you look at the cost of your last cotton wool swab or your last alcohol swab is billed. Okay, if you get your statement, every last penny is accounted for. Okay, so the model behind a business in the private healthcare system is it's underwritten by extreme accountability, right? We want to measure every single alcohol swab that we use and tally it up to ensure that everything is within a framework of profit. Okay. And the state healthcare system is just like, I mean, we have 100 billion rand budget per annum, for instance, and we need to sort out our healthcare services across the country through the various provinces. So the discussions, the mindset, the framework of understanding is very, very different. Okay. So unpacking this, private healthcare sector, the ethos, the motto is business driven. It's a business model of funding. The healthcare system is more service delivery at the cost of the government, or at the discretion of the Department of Health and the funding that comes from the Department of Finance. Okay, so in the maybe let's walk you through the journey of a healthcare professional, right? And this is where I think people find it very difficult to understand, why is my doctor charging me so much? And why is you know, my psychologist or my anesthetist or my surgeon charging me so much? And I want to highlight, being a business-driven model, it's a system of different components that make up the private healthcare system. And all these components kind of work together, right? The pace, the tone, the manufacturing process, the input, the output is all determined by people in the private space, right? Which are largely, um, you know, business-owned healthcare facilities or establishments, business-owned corporations, business-owned chains of hospital groups. Okay. And with any sense of business and consumerism, there'll always be, I mean, it's return on profits, right? How much are we getting in terms of this healthcare sector? So yes, we are providing the service, we are saving patients' life, but that's not the primary core of our business. Our business is profit. As a healthcare practitioner, when you're done with your qualification, you're done with your specialization, and now you're entering the world of this so-called and by and large, just to highlight that one of the inefficiencies of the healthcare system is obviously lack of employability of healthcare workers, doctors, nurses, everybody. So the private is by and large a huge alternative, or it's a significant alternative because there are no government posts, government funded posts. So naturally, even if people decided to stay in the government sector to help and to be part of a system that's always drained, they don't have the opportunity to do so. The only other way of income is in the private healthcare sector. Right. And that's why majority of specialists do end up, or alternatively traveling overseas and finding other opportunities. Now, as a young specialist or as a young general practitioner going into the public world, understanding that, you know, they it comes down to a sense of internal conflict, because throughout your medical journey, you're driven with this sense of altruism. I'm going to do for my community, right? But at the same time, in our communities, there's a sense of, besides the status symbol of you being a doctor, there's a sense of feeling that, you know what, doctors earn a lot of money. Okay. To a certain degree, there is truth to it. But for the most part, I honestly think, and this is my humble opinion, that there are far more greater, easier, more sustainable ways to make lots of money than in healthcare. And I always advise this to, to listeners or parents who are considering this as a profession. If money is your driving factor for your child's career to being a healthcare provider, then please save them the trouble and save them the difficulty of strained mental health, and rather let them find other careers if money is a primary driving factor. Anyhow, so coming back to the footsteps of a young specialist, a young junior doctor going into the private healthcare, your primary instinct, right, is to work in an environment where you can contribute. Yes, you do charge for your services, right? But you're entering a system that's in a way almost controlled, and just a prelude in my mind to this podcast. I was thinking, what's the example that we can give where that I can relate and associate the private healthcare sector to other parts of our socioeconomic sector in South Africa. And I don't want to use the word fixing, right? But we know, for essential commodities like bread, flour, prices are generally fixed, or they are tax averse to a certain degree, right? Because of the essentialness of it. Healthcare is an essential service, right? So there is room to gain back, like a tax rebate on certain equipment and what have you. So there is benefits and advantages to running a profitable healthcare practice, or profitable healthcare business model. Okay, so as a young doctor, you come with the sense of, I want to do for my community, entering a strong world of capitalism. And let me be absolutely frank about this: nobody teaches you about business in medical school. Nobody tells you what it's like to live as a doctor, trying to earn an income from your profession in the outer world, right? A lot of it has to do with your inner sense, your value of a person, your morals, and this can be guided by faith, by religion, by your community and your family upbringing. Lots of it contribute to your personality as a person. But now you're this isolated figure. You're entering a world that is capitalist driven, that is business driven, that is profit driven, right? So your whole framework has to adjust, has to adapt to what is happening around me. I need to survive, but at the same time, the conflict that comes in within healthcare providers is, I can't be greedy. Okay. And it kind of starts off like that. I think in my experience with other healthcare professionals, for the first 2, 3, 4 years, it is like that. But then there is this constant pressure on the system once you start dealing with subsidiaries like medical aids, like hospitals and all healthcare service providers, and you understand how the system is controlled in a sense that everything revolves around money. If you do not have money, you cannot access healthcare, right? In the private space. If you do not have medical aid that will stand guarantor to paying for your admission, you cannot access medical aid. Okay. So there is a sense of, for lack of a better word, high degree of control attached to the system, right? And all of us are just components. Healthcare providers are components. And I'm not saying, it's right or wrong morally to charge exorbitant fees, but I'm trying to build a discussion around how people end up in the system, almost clasped, almost caught. And it's a system you can't truly avoid from, because let's say you try to be against a system that is capitalist driven, right? You're an isolated figure, and to earn a sustainable income is very, very difficult, unless, of course, you have generational wealth, right? But as somebody who's from low to middle class income, or maybe low income household, being a doctor, having student debt to pay off. Now you're in this private healthcare system where everything is profit driven. It comes with lots of personal challenges, right? But it builds up and you kind of swim your way through, right? Then there's the whole concept about exorbitant charging and how this comes about. And I want to maybe bring about some components of healthcare, the private healthcare, that kind of set the standard of what specialists should be earning, like an approximation, right? And this is driven by, an accepted rate of society that has been kind of initiated and sustained for a long period of time. And then this is also driven by, medical aids and other healthcare funders to say that we will pay this amount for a certain operation and stuff. So there is a general idea, there is a general consensus around what specialists would earn in a particular setting, right? Because most of private healthcare funding is driven by medical aids, and medical aids have a kind of a model that they use in which to say that for the specialist or the surgery, we will earn this much, okay, or we will pay this amount. So it's kind of universal across the board, and it's generally higher than usual.
If I can come in here, sorry to interject, but this is important. You've outlined basically the two different, let's say, paradigms that are existing. The public healthcare system, service driven. There's, there's 60 million people in the country. We need to service all 60 million people, right? From someone that comes in with a paper cut to someone that comes in with very complex medical problems, which I won't even attempt to describe because I'm not a medical doctor, only level three first aid from St. John's, right? That's as far as it goes, right? Coming with sophisticated problems, and it's geared towards, so the intention is we're servicing everyone. And on the private sector side, it's like, okay, you know what? Service, yes, but ultimately this is a business and the business has to make profit and the cost of this business, whereas the state is going to absorb cost. Here, the cost is going to be borne by the patient, right? But like you've mentioned as well, there's a capitalist mindset, right? And we know, unfortunately, it seems like when it comes to anything involving the capitalistic mindset, ethics are like kind of like, unfortunately, like, a little side project that shouldn't really affect the main business, which is the business itself. Now, you are a Muslim, you're an alim, you've been practicing medicine for a while, and the ethics of this here, because we do know, yes, a business must generate profit. We do understand the models that exist, but South Africans, the average South African is saying, look, I understand that my private healthcare is going to cost me more, but right now the costs are more than 3 times, perhaps the amount that it would have costed at a government hospital. So my question to you is that, well, firstly, what's the true cost of, medical service in government hospitals, that the cost that the state bears, and then secondly, the the inflationary pricing that we see on the private sector side, is it really beyond the pole, or is it actually reasonable?
here's the thing, right? From a costing perspective, and I do stand for correction, but I'll try and elaborate as best as I can. So there are instances, for instance, where you have private medical aid, but some private hospitals cannot give you the type of service that you need, which might only be able to happen at a government facility. Remember, all specialists train at government facilities before they enter private, right? There's no private, well, there are some private training facilities, but under supervision. But for the most part, most specialists specialize in government facilities. So there are certain instances where the state facility can offer a service that most private people cannot. I'm talking about like extreme, a form of a multidisciplinary transplant, or something quite severe, quite significant. So you, with your medical aid, will go to the hospital, and the hospital will charge the medical aid. Okay, right? So let's say if that same procedure has to be done in private, right? With the whole, yes, it would be inflationary, right? But it doesn't mean that the hospital will charge you a nominal fee. Okay, they will charge you proportionally, and the hospital has its own funding model and how they charge private patients. Okay, so yes, the hospitals, if you by choice, you can also go to a government hospital. If you have medical aid, you can go to a government hospital and they will charge you medical aid, right? But in my experience, it's not as inflationary as it would be in private. So in the private healthcare system, um, a lot of the procedures are, I mean, look, depending on the severity and the type of care that you need. Okay. So you gave a brilliant example of a paper cut versus somebody needing a kidney transplant. Okay. Right. So a paper cut, I mean, the costs would be much far lower, right? Still inflationary, but far lower compared to somebody needing a transplant, which, in average, I mean, I'm sure some of our listeners can attest to this, is that if you've been hospitalized and had it not been for your medical aid, most people who are from that 9% would technically be bankrupt. I'll give you a case in point. Just to bring some of the maths into the equation. Um, Recently, there was a birth in the family, and baby had to be in ICU for approximately 6 weeks, 7 weeks or so, plus minus. And the hospital bill for the 2 month period, plus minus, came to approximately 850 odd thousand rands. Okay. So yes, fair enough, it was extensive care, and they charge for specialized services by the minute or sometimes by the day, and the type of resources that they have. But on average, I mean, there is private healthcare goes into the billions. Okay. It's very, very, very significant. So I would not be surprised. Take the incidence for COVID. COVID was, in as much as a lot of us lost loved ones, and it was truly, truly traumatic for both healthcare providers and patients who stood to truly benefit from that. A lot of people were on ventilators, a lot of people were in ICU. So I mean, the private healthcare sector did profit, right? And with their funding models and the type of resources they had to utilize in order to ensure adequate healthcare, I mean, the funding model is quite significant. So, if let's leave medical aid aside, and there was no concept of medical aid, I doubt that the private healthcare would have been inflationary as it is, because they wouldn't have had clientele, right? So you and I, from our own pockets, if we had to pay for private healthcare, it would not be feasible for private healthcare systems to exist because of that inflationary rate, right? I don't think the only people who would technically truly afford it in cash rates rather than medical aid would be ultra wealthy, right? So you designate the hospital for a whole royal family type of thing. That's how it would be. So the private institutions know that they can profit because of the concept of medical aids, which ironically happens to be registered as a non-profit company. So it's a very interesting matrix, right? Between the consumer, what the medical aid has to provide for me, and how much private organizations can benefit from money that medical aid gives to them. And this whole matrix runs into the billions. let's take nothing away from the fact that the healthcare providers themselves, and I'll speak specifically about them to address the concept about why my doctor is charging so much, right? So I think there's a sense of exploitation um, based on the leverage that private healthcare funders or medical aids have. For instance, a colleague of mine told me that, again, crunching the numbers, the medical aid would only pay him 220 rands for a consultation. Okay, which the average in his area would be about 350 plus minus, right? A general average consultation, which is generally acceptable. Okay, it's not an inflated amount of like 1,500 rand, that some people use to pay specialists. It's an acceptable rate between people or in communities. So the medical aid only pays him that, but the medical aid knows that he's under duress because um, he has to take the client. He's not going to get a client that will pay him cash 350. The client would rather have the medical aid pay him the 220 and the balance as, a cash supplementation or above medical aid rates, as they call it. Now, this is the only margin truly where doctors have the opportunity to, you know, um, capitalize extensively, right? So I mentioned earlier that there's generally kind of universal rate model that is given for certain procedures that medical aids would cover. For example, like a cesarean section, very common in our community. Medical aid might pay approximately 25,000 for that procedure. Okay. And the surgeon himself or herself can decide, well, my value is I prefer 50. So surgeon will charge the patient 50,000 for that procedure. Some medical aids may pay up to it, sometimes not, then the patient's liable for the extra amount. Okay. So, but then there is a universal acceptance practice. Where the exorbitance, in my understanding, comes in is where the medical aid is giving you a certain amount, you're charging a little bit above that. So coming back to the 220 example, right? The medical aid's giving you 220 for the consultation, you charge the patient up to 350, which is acceptable, reasonable in a way, right? And I say this with tongue in cheek. Reasonable is very subjective, depending on the community that you live, what's the going rate, all of that affects the general pricing model. Then comes in, a particular surgeon who would charge maybe 500% on top of the medical aid rates. So let's go to the obstetrician again. 25,000 Rand is what the medical aid would pay, right? This obstetrician says, I'm going to charge you 100,000 Rands, right? They're providing the service. You can choose whether you want it or not. You can choose to get another obstetrician. Most people don't usually realize it until the final statement comes. When you get admitted to hospital for an emergency, everything revolves around that emergency. A lot of the billing and funding and statements all come afterwards and sometimes takes a few months to settle, right? So this is where I think the margin of exorbitance comes in, where a healthcare provider decides to charge significantly more than what the medical aid rates would be. And some of them do it with the intention that let's just test the waters.
Yeah.
Medical aids would pay us. Let's just test the waters. Let's charge 500. Maybe the medical aid will give us 300% on top. So we're still scoring. And what is their rationale? Their rationale is, well, the patient's not paying anything. The medical aid is paying. So I'm at liberty to charge exorbitant fees. And this is the counter altruistic side that comes to it. Let's say if the medical aid doesn't pay the 300%, right? Then it's fine. I won't let the patient pay anything. Okay. So
Okay.
doctors themselves, understanding this concept, or specialists themselves, test the waters a little bit, right? Alhamdulillah, in my experience, the colleagues that I have generally worked with, I've never experienced, firsthand with my family or anything like that, but I am aware. So, and also exorbitant, right? It's quite subjective, right? How do we measure? How do we crunch the numbers to explore what exorbitant is? So, in my understanding, that's what I'm trying to explain. The acceptable going rate up to that is fine. Once you start going beyond that certain point, for the same type of service that any other GP in the area or specialist can give you, that's when it becomes a bit tricky.
Another area where it would be tricky to determine whether rates are exploitative or not are practices in medical fields where the medical aids or medical aid schemes usually don't contribute. So, for instance, like fertility care, I've noticed that a lot of, for instance, fertility doctors don't accept medical aid. So, a lot of the payments are cash. And there, of course, the doctor can make his own price, and you have to pay. It comes out of your pocket as a patient. Also, doctors who specialize in cosmetic surgeries, that kind of
Yes.
thing. So perhaps for someone in this capitalist environment who is maybe a bit more of a businessman, um, wants to make money and capitalize on that, then those are the fields where they can, make a killing. And those fields are usually, I think, niche, or I don't want to use the term luxury treatments or luxury fields, but it's usually fields that aren't all that accessible globally to people who are of lower or middle income brackets. And so I suppose part of the motivation for not accepting medical aid is that the doctors have this kind of understanding that the patients that they usually treat are capable of affording the treatments.
Definitely. I think it's look, I mean, for services that medical aids usually don't cover. So medical aids are guided by an organization called the Council of Medical Schemes, right? They regulate with absolute necessity what medical aids have to provide and what is not as essential for them to provide. So medical aids would look at the absolute bare minimum and like a hospital plan, for example, and be like, okay, this is the bare minimum. And then subsequently, if you want the cosmetic and a higher medical aid plan, they would cover certain elements. But then you're looking at a cost factor of about 8, 9, 10,000 rand per person monthly. Okay. So doctors involved in fertility and cosmetic surgery, remember their niche market is people who have the money, people who have the cash. So yes, you're absolutely right. They can call their pricing, and if you have it and you're willing and you want to, then by all means. And look, in that space, it's also a very competitive industry. Okay. And I must say, this system, this capitalistic profiteering system breeds a sense of extreme competitiveness between um, between doctors, between healthcare service organizations like hospitals, but you're taking my patient, and why are you taking my patient? And only I'm allowed to admit to this particular hospital. So everything is worked in a system, in a group, right? When you enter the world of private healthcare, you connect, you associate yourself where, you're swimming, but you've got support. There's lifeguards around you, type of thing, until such a time you become equipped yourself, and you're confident enough to charge the rates that you want, and that's generally the scheme of private healthcare. So in essence, it's significantly a different space, a very competitive space, a very profit driven. There's a much as people say, but no, I'm a good doctor and I just charge what medical rates. Alhamdulillah, I mean, good on you for that. Good on you for trying your best. And here's what I'd like to add is that, you know, in my experience, um, in the private healthcare sector, uh, doctors, nurses are also human too, right? Everybody has different vested interests. Everybody has different ways of approach to it, and sometimes I think the altruistic side comes out in terms of the type of service, right? So money aside, I think what what can be said with truth is that even in private, people will tell you that I received wonderful care, and yes, obviously money is paying for a lot of it, but there is still that sense of kindness, that sense of humanness, of caring for the next person. And I think a lot of it is reflected in the private healthcare because the numbers are far lower. So you don't have one nurse treating 30 people. You have one nurse treating a group of 10 people. So that whole component of a human resource management is much more managed in the private healthcare. So overall, yes, it is a holistic experience. You are paying for a service. And the question is, do we have control over exorbitant rates or not? In a system that is already kind of fixed, for lack of a better word, in terms of the rates, in terms of the funding models. And you as a solo entity cannot find the space to challenge that. The only way you can do that probably is going and saying, look, my name is so and so, I'm a specialist, I charge 600 Rand for a consultation, that's my fee, and that's it. Right? But then remember, all the people around you, all the components around you also have a sense of profit or income generation. And they're not going to be like friends with you. They're not going to be, you're not part of the network. You're not part of the profiteering network. So it becomes very difficult to challenge a system that is so business driven. And I think that's the reason why a lot of the times costs, private healthcare costs are extremely exorbitant.
Essentially, what you're describing is we have, the private healthcare schemes, the medical aids, and so forth, right? This year, the majority of it was developed, created, and is run by essentially non-medical practitioners, right? These are businessmen, these are investors, these are managers, these are administrators, and they're treating it like any other business. And then there's the ethical component of the medical practitioner that's involved. Now, this is really the crux where we are at, is that, for example, what ethics does the doctor or whatever expert is involved, whether they're a doctor, whether physiotherapist, whether it's an optician, an optometrist, that personal ethics that we bring forth? Because, like you say, if you start to do, start to run practice in a way that it's so altruistic, you're essentially cutting cost. You are now basically rebelling against the system. You're going to be excluded from the profiteering network, and you definitely are going to be the most hated person within the fraternity, because you're going against the grain, where everyone was basically you're basically threatening the golden goose. Now, as a Muslim, where does the Muslim practitioner come in? And we also have to look and things that you were mentioning earlier about, for example, our own the Ummah's own resources in the form of waqf and other schemes that can be used to bolster a more ethical approach towards private practice. What would you say there, inshallah?
See, ethics is a very, it's from a Muslim viewpoint, right? Our ethics, I think the first thing as practitioners we need to appreciate is that working in healthcare, in a sense, is amana. So part of our ethical framework is to adopt this amana in a way that we accept the responsibility for helping, serving in an altruistic manner. Yet we are given Islamically and from a Shari'i perspective, we are given the opportunity to charge for a service rendered. Okay, and I think nobody's. Here's the thing: one extreme is I've experienced some colleagues of mine who, in their heyday, they were so altruistic that after medicine, they decided to join global organizations, and, mashallah, fi sabilillah, their whole lives. Alhamdulillah, illa mashallah, there are people who are like that. But for the common person in a two-tiered system like South Africa, right? I think understanding that our practice of medicine and healthcare is an amana in itself, where we need to kind of balance our values without compromising on who we are as Muslims and what we represent, right? And what Muslims represent, look, if you're in the private healthcare and if you use the business model as an example, it's not incorrect to sustain profit, right? But where the profit becomes a sense of exorbitance, such that it generates a sense of greed, malice, hatred for your colleagues. It breeds about a toxic environment where, case in point, if I've got a successful practice and I see a young specialist running up or coming up, there's no harm in, sending patients his or her way. There's absolutely great good in, showing them the ropes, telling them what mistakes I've learned from. So the type of support that we need to create for each other is extremely important as Muslim healthcare practitioners, especially in a very capitalist run system.
Shukran jazilan for that. Before we close, one final, comment, inshallah. Essentially, what you're saying is that given the current system, the best that Muslim practitioners can do is basically bring their Islamic ethics, the Islamic worldview into play into the current system. But that doesn't, you know, essentially say that when a better system is proposed, whether it be from state, whether it be from even from the private sector itself, that the Muslim practitioner needs to, essentially reject and refuse a newer, more hopefully more just and more equitable, system that may present itself in the future. And what's being presented in South Africa right now, what's on the cards is the NHI. So, in summary, you as a doctor,
Sure.
are you in support of this? What are your fears? What's your hopes? Any anxieties regarding NHI before we close?
I've been trying to do more extensive research on what it is and how the government is trying to sell us this, right? So the right side, or should I say the left side of my mind, is more keen to thinking that the NHI is just another way in which, government can enhance already existing corruption through tenderpreneurs. Because what in essence will happen is they will have the monopoly of literally every facility in the country, private or state. And on the flip side, though, the monopoly will also entail a universal model of funding and a universal model of payment. So rates for specialists will be capped, rates for GPs will be capped. Any person can come to you at any time. You don't really have the right to refuse health to anybody, right? Even in your private practice. So there's lots of discussions in what's happening with that. And I think I wouldn't say it's so much more probably a socialistic type of model, for lack of better words, where everybody's granted care. And I think part of this reason, and if you look at universal care, Obamacare, and other parts of the world, the NHS in Britain, the UK, for instance, right? Canada also has a very almost a one-tiered system. It's absolutely it hasn't answered the questions about accessible healthcare. Okay, it's fatigued, it's a very drained system, and government is being, injecting money very, very significantly, but it hasn't truly materialized into the objectives of what universal healthcare should be, to the point where specialists, doctors, everybody's complaining about this type of model. Okay, so already we're starting on a foot that is, debatable in terms of effectivity of it. If you look at the very quickly, like a contrasting. I mean, when back in our day when we were schooling and OBE was a thing, right before the onset of CAPS. I mean, after how many countries, it went through a phase that unsuccessfully enriched, and just globally looking at that type of model and trying to see if it's going to work truly in South Africa. I mean, I'm very skeptical. And number two is the funding proposal and how much of money they envisage that's going to need for universal healthcare in South Africa. I mean, sure, subhanAllah. I don't know how many more budget speeches we're going to probably need to hear in order to raise that amount of capital in to get it in motion. So they're trying to do it in a phased process, like slow, inject some capital, start some sort of service, and until the point where we reach completely. But here's the thing: NHI is here to stay, mostly because it's signed into law. All right, so we're not anticipating that it's going to go unless, I mean, medical aids and board of healthcare funders, they're challenging the NHI type of situation, and obviously they're under threat, right? That's the only reason primarily why, and it's almost a dent to a profiteering system. That's my opinion. Okay, it's a dent to a profiteering system, and I take a little bit comfort to know that the objectives behind it are good. I just don't see, with our rates of universal corruption, building a sense of true universal healthcare in South Africa. So for now, there's a lot of talks around the legislation, how it's going to be enacted. And I think doctors are also a bit skeptical. Some of them are a bit hasty and have left and gone overseas. And I'm like, but why? We need you here. I mean, we can't have all our good specialists going and, servicing other populations in the world when we have the highest rates of HIV, TB, and so many other, medical comorbidities in South Africa. But nonetheless, inshallah, my thoughts are, I like the ideals behind it. I like the objectives, what it's trying to achieve. Are all very noble, all very socialistic, and some people might even say communistic, because everybody receives exactly the same type of healthcare regardless of where you are, right? But the implementation and how that can give rise to, so what, the lesser of two evils, if I can put it, because in the private healthcare system, there is groups of organizations that are profiteering really significantly. This time around, however, the profit sharing might seem like it shifts towards people who are already in the state and already service providers to the state. They just, hopefully not, but probably get a bigger chunk of the pie. So I think it's shifting the dynamics between where the money is spent. And I mean, that's the whole discussion for another day.
Hope for better days, inshallah. Muhammad,
Inshallah.
it has been fantastic engaging you, always bringing a lot of depth and clarity to the discussions. Jazakallah khairah for joining us. Shukran jazilan. And we look forward to engaging you further on this when NHI is actually now kicking in and rolling out, and to have a much more engaged discussion, inshallah. Oh.